welcome to the Virtual Physiatry Mentors. I'm Dr. Sheena Bhuva.
I'm Dr. Benecia Williams.
And together we are
Benecia. Oh, yep.
All right. Well, today we have our good friend, Dr. Jason Williams. He is...
Jason Williams? Jason. We're just messing. All of us, we're all...
Our good friend, Dr. Jason Miller. Shanisha, Jason Williams, that's how it was. We were also known as the Dream Team. We all went to residency together. Just the three of us were in 1 year. So Dr. Miller, Jason, is the medical director at an inpatient rehab facility, and he also works in the same organization where we train. So we'll go into a little bit of detail about that and some of the pros and cons and kind of Dr. Miller's journey through all that. So
Jersey
and journeys, yes.
And let me put this out there that I have a Dream Team jersey as well, but when I moved out of Dallas, it is in storage. So that's how into ourselves we Jason got these for us when we graduated.
Yeah.
We're so excited to have you on, Jay. Yay.
Well, thank you.
Yeah. So tell us more.
I haven't seen you in so long.
I know, the pandemic, we usually try to do stuff a couple times a year, but the pandemic has really killed it for us. So I'm glad that we are able to catch up this way.
Yep.
That's the fun part about this podcast. I call it the fun cast.
We are making all sorts of new words today.
That was a good one, huh? Fun cast. We know all about you, but Jason, please tell our viewers about yourself, your educational journey, where you're from, and all the fun stuff.
So I'm from Southern California. I went to high school in Huntington Beach, went to college in Orange at Chapman University, where I majored in exercise science. Then I went and was a trainer and a therapist for 8 years before going back to medical school, where I went to the College of Osteopathic Medicine of the Pacific in Pomona and got my DO degree, did my internship in Long Beach at Pacific Hospital in Long Beach, and then moved out to Dallas to finish my PM&R residency at Baylor, Dallas.
All right. And you played baseball in college, right?
I did. I played baseball in high.
Is this my end or this the end?
And they won it the year after I graduated.
There we go. All right, you're back. All right.
And now I play golf.
And you play golf, yes, Jason.
And now I play golf.
He's like a semi-professional. Oh, I already know what the answer is going to be for that last question, but he's a semi-professional golfer. Yay.
So, as we alluded to in the intro, we all went to a very small residency program where it was 3 per year, so 9 total. And so what was your experience like, Jason, being part of a small program, and how did you get along with this?
That's crazy, chicks.
I felt like the small program was a very, family-like atmosphere. I felt very connected to the senior year, the senior residents when we started, and felt like they passed on a lot of knowledge to us that was very helpful getting into the residency, and then especially going to one outside of the state.
Audio issues.
We're having internet.
Us, and I think we clicked really well, from early on, where we got to spend a lot of time together. Our first year doing inpatient at BIR, and so we were there to support each other, and then as we got older, to share that knowledge and encourage
raise up our babies.
Yeah, which some of them needed lots of raising. But it was it was very supportive atmosphere, and even the doctors, being a relatively small staff that we trained with too, they were all very invested in each and every one of us. because they could be, with only 9 residents. So I felt like that was good for, for all of us, and them encouraging us in our separate paths that we would take, but they knew which, what we liked and what we would excel at, and try to help us do that, to the best of our ability.
For sure, there's no slacking off in a small program. We had Dr. Sika and Dr. Chung on a couple of weeks ago, and we were talking about how fast Dr. Chung was with the notes. And he'd be like, I'm going to start from the top, you start from the bottom. And he would always beat you, like, no matter how fast you were. Oh, our number 1 fan's on. Hi, Kelly.
Hi, Kelly. I'm like acting like I don't see her.
I know. She says nice. I know. I'm sad I don't have mine.
And we've talked about this in the past too. Kind of one of the big benefits of being part of a small program is you get to study with each other. And for when we were studying for our boards, we just split up, Cucarillo and some of the other resources, and just met up every month and reviewed a chapter together. And just that closeness of just being able to get to know each other through those 3 years kind of really brought us through. And where we're all different, we have different beliefs and all sorts of stuff, whatever, but we still support each other. And so that's kind of awesome to have. So
yeah, I know, I don't think personality wise they could have matched up any better than us 3. That's why I'm still convinced we were the best class I ever came. Dream team. What can we say? So Jason, now you work with all the attendings that trained us. When you started looking for a job, what were you looking for, and how did your current job opportunity come up?
Well, I was looking for something where I can do a mixture of inpatient and outpatient. I thought coming into residency that I would want to focus just on outpatient, musculoskeletal, because that was my background, doing personal training and massage therapy, sports training and that sort of thing. But I really grew to like neuro rehab and, the different aspects of dealing with stroke patients, as well as the orthopedic patients too. So I did come to love inpatient medicine, but I did want to keep up my skills with outpatient as well. So I was looking for something that would give me a mixture of both. And then also starting out, I knew that inpatient would be a little bit more consistent. At the time when you're trying to build an outpatient practice, very early on, it can take a while. So having work to do while you're trying to build up that outpatient practice. So that's
having butts in beds pays bills, huh? I said having butts in beds pays bills.
And that's very good advice. Yeah.
When I was starting to look for a job, I asked program director where if they knew of any jobs, and I asked other docs that I worked with, some in California and some out in Texas, and just looked at some of the different opportunities, because I figured if I was gonna leave Texas, it would be just to go back to California, to where my family is. But I looked at the different opportunities, and the one at Grapevine seemed to suit my needs the best, and where I felt that I would fit in and my skills would be, best used at that time. So, and also opportunity for growth there as well. So.
And I talk about this, like inpatient rehab is different, like in an academic setting where you have the residents all the time versus like a community inpatient rehab, right? Right. I liked the community, like, I'm on inpatient rehab right now. That's where I was this morning. And I enjoyed that a lot more than I did like the academic side of it for some reason. But maybe it was because I was in residency, and that probably made a difference. When you get paid to do that, you tend to enjoy things a lot better. So.
Well, yeah, when you have a little bit more control over your schedule and everything, that helps make it, you can make it your own. And
it makes a difference. So, yeah, when you're on your own schedule, for sure. Because I'm like, I woke up at 5:30 a.m. this morning. I was like, I'm just gonna go in a round right now. I might as well. I'm like, get done early.
Yep.
Nice.
All right, Jason. So tell us a little bit about, this opportunity came up, but sometimes it's a little bit awkward in sense of like, negotiating contracts and when it's people that you worked with, then also, and, thinking, whether or not are they going to be seeing you as the same level now that you're an attending, or are they still going to be thinking of you as, one of, their residents and like that. So tell us a little bit about what went through your mind when signing the contract, and did you feel, what were some of the pros and cons of working where you trained at? Because we have some PGY4s that will probably be watching this video and they're looking for jobs right now, and I'm sure there'll be opportunities in their own programs. And what are some things that they should be looking out for?
Well, I mean, I think I was lucky in terms of I was very early on in my fourth year where I started looking and had kind of narrowed it down. So I made my decision before Thanksgiving, my senior year. So because I think I looked at the offers and, looking just plainly at the offers, not who's given you the offer, not taking it personally is important, but also knowing your worth and talking to some other people to find out what is competitive. And so, not to sell yourself short of what you could get, but, accepting what you can and would, give up in exchange for other, other perks or, advantages, I would say, so when looking at the different offers from, big organizations or private, maybe partnerships or private offices, they're all going to have their pros and they're all going to have their cons. So just think about what is the most important to you. And so, it wasn't as much did I feel like they were giving me what I deserved or what someone else tells me I deserve, but what is most important to me, and am I getting that out of this job? And that, that's what made the decision pretty much, easy for me. And in terms of working with the doctors that I train with, I think I might have had a little bit of advantage because I was older coming into residency, having a short previous career. But I mean, I was older than some of the attendings I worked with. I'm older than Down, and I'm older than Steven. So I felt like I was being treated as equal, at that time already, as a senior resident. So, and that's why I think I was offered the medical director job that a lot of, PGY4s might not be offered right out of residency. But having some additional life experience, I think, made them feel more comfortable with me and offering me that position.
Taking that role on. Mm-hmm.
Yeah.
I think that our residency does a good job by the time you're PGY4 by kind of letting you run the show. Like when you're on inpatient on PGY4, like you are making the calls. They're like, what do you want to do? You're like, this is what I want to do. They're like, okay, sounds good. That's what we're going to do. So I appreciated that. So tell us, and you talked a little bit about becoming medical director. What exactly does that mean? What's your role? And then walk us through like a week of your job, what your schedule looks like.
So being the director at the inpatient unit at Grapevine, I basically get all the referrals to that unit, and I have to, review them and decide whether they're appropriate, and then, all that goes into looking at their monthly and yearly compliance data that gets reported to CMS for every inpatient rehab facility. So we have to have the 60% Medicare compliance rule, making sure that that 60% of our Medicare or managed Medicare patients fit into one of the 13 rehab diagnoses, and then also that all our patients are meeting the 3-hour requirement, or the 15 hours of therapy over 7 days requirement. So that's, I go over the compliance data with the, with the liaison, with the admissions and that sort of thing. And then for the therapy compliance, I work with the therapy department on that. So there are some, sometimes it's hard to get patients in when you have to, you're kind of toeing the edge on either of those, either, the 60% compliance, because if you don't meet that for the year, then you could get audited by Medicare and you have to pay back a bunch of money. And the same thing with the 3-hour compliance rule. If they don't feel like you're taking appropriate patients that can do that are getting all the therapy that the facility is getting paid for, then you might have to pay back a bunch of money to Medicare.
And so I want to kind of just chime in for some of our audience members and why physiatrists are so key at that, because it is our job to kind of look at a person's, when you have a referral to inpatient rehab, to review it and seeing if a person is appropriate. Because a lot of people are like, oh, why not just take anyone? The reason we just don't take anyone is because CMS will come in and tell you will get in trouble by Medicare if you do. So it's important to be ethical, but that is your job as a rehab doctor, is to find those key patients that would benefit.
Right. So during the week, I have, I go in and round, usually in the morning, and sometimes I'll go to trauma rounds and talk with the trauma team on patients that are there, and looking with the trauma surgeons and the acute care therapists to try to help find the appropriate place for them to go. And then, with our unit, we have team conference twice a week. And so we work on their discharge planning for when they're ready to go, equipment they need, and for the therapy they need, get all those things set up so that they're, ready to be successful when they get home, and their families too.
What time do you usually start rounding?
Usually between 8 and 9. And then when I'm usually done doing that in a couple hours, but then I look at the new referrals who might be coming in the afternoon, and it's nice being able to see some of those that are in my hospital already. If they're going to come, then I can see them before they get to the rehab unit. The other ones that are coming from outside hospitals, I usually wait until they get there and see them, and then I'm done for the day.
Do the majority of your patients coming from your hospital, would you say?
I'd say probably 60-40 right now.
Okay.
It was a lot more, when I first started, but we've gotten a lot of other hospitals around now that send us quite a few referrals a month. So it's probably 60-40 now.
That's good. That's really good.
What's the usual? Oh, go ahead. I was just going to ask, what's your usual census?
Well, it was between 8 and 14, but now with COVID, we're limiting it a little bit more because we can't group as many patients as we normally do. Trying to keep everyone, appropriate distances. So we're limited to 12 right now. So
that's a nice day,
we've been, the last couple months been pretty busy, and so we've been between 10 and 12 a lot of the last few months.
I think that's a perfect number for me. Like we have 18 in our unit right now, and I'm like, but like 10, I was like, oh, I can push through 10. I'm ready to get them done, get them in and out. I can go do outpatient clinic. I can go see some acute consults. But yeah, that's a good sweet spot.
Yeah, with our therapy staff is pretty small, and so when we get up to 10 or 12, we have to get some help And
Yeah.
So sometimes if that happens fast, if we get like a bunch of admissions in just a couple days, it's hard to find that help, because they've, the ones that we have a PRN are, they're committed elsewhere.
Right.
So sometimes it's hard, but then there's days where we have 4 and we're trying to find work for our therapists to do.
Yeah.
That's kind of why we can't keep a bigger pool all the time, is because we maybe
Staffing.
4 patients for a week or so, and then the therapists don't have anything to do. So it's 8 to 10 is like the sweet spot. It keeps everyone busy, and just maybe needing 1 or 2 therapists here or there to help out, which we can usually find.
Are you seeing any post-COVID patients?
Yes, we've seen a few.
It's
most
such a
of the ones that
spectrum.
were treated, most of the ones that were treated at Grapevine, and then some of them went to LTAC, for vent weaning, and came back. Saw some that were not on the vent so long, that were definitely in better shape. But a lot of things that they're going to have going on for a while after recovering, when they had severe illness like those ones did.
Mm-hmm. It's crazy, like the spectrum that I've seen, because I go to Kindred LTAC, so it's like some of these patients, it's the saddest thing I've ever seen, and you just never know. No one's exactly the same. They're just, some are like anoxic brain injury, some are critical illness, myopathy, and neuropathy. It's just insane.
Yeah.
It is. If you guys have any questions, let us know. I do have a question. Tell us, what's the benefit of being a medical director? We know the answer. If you get, usually it's financial benefit, right? For those that don't know, you get like a monthly.
I get a stipend for, I bill for hours that I spend doing medical director work.
Like administrative type stuff, right?
Right. So that's what I get billed per month for that. So,
and you can carry multiple medical directorships. Like if there's some doctors that go to like multiple different skilled nursing facilities, and it's a nice way to supplement your income if you don't mind doing that administration. We're the medical directors at Medical City Fort Worth, so it's nice supplement. Yeah,
there's definitely going to be some work to do there, but I'm hoping that they continue to have physiatrists be the medical directors at all of those facilities.
I wonder about, like, my prediction is like inpatient rehab. I wonder if it's going to be around in 10 years, because the way that insurance is dictating care,
it's ridiculous.
It's getting out of hand. It is. I feel like it's getting out. Like even like CMS 13. I literally did a peer-to-peer the other day, you guys, and I was like, I'm not really for sure why I'm doing this peer-to-peer. I said, this is a CMS 13 criteria. This patient is a perfect inpatient rehab criteria. And the peer-to-peer was like, oh, what's CMS 13? I was like,
like you hear all these stories on people posting on our Facebook pages and stuff. It's ridiculous.
Yeah, and I was like,
we have some groups out there vouching for us, PM&R and some others that.
Because it's like it's so many people just don't know what we do, but if you know what we do, you realize what a service it is to have a PM&R doctor on your side. Like even for us to be able to see patients on the acute side is huge. Like it's nice when you have a referral come in from us, because Jason will call me like, he'll be like, can you please get a referral from Dr. Williams to go to this patient? And I'm like, yes, I will. I'll go see him today.
Nice.
It's nice.
All right. Any other questions, guys?
I know. I've been so quiet. I'll go back and watch it. Well, I'll ask our famous question, even though I know the answer. If you were not a PM&R physician, Jason, what would you be? And I want 2 different answers. I want one in medicine and one, I know what the out of medicine one would be.
Yeah, I think I told you when I was looking at what I should do and deciding about medical school, I said, well, I'd like to be a professional golfer or a doctor, but I think someone will loan me the money to go back to medical school. I don't think they'll loan me the money to become a professional golfer. So that is what I would do. And then in medicine, I mean, I think the other thing I would want to do is be an orthopedic surgeon. I like fixing things with my hands, but when I was trying to decide in medical school, I was like, my hands are kind of shaky sometimes, so maybe I don't want to go and operate on people. But after seeing what they did with all the hammers and the saws and everything, I think I could do this.
Yeah, I remember the very first orthopedic surgery I scrubbed in on as a medical student. I was like, this is so barbaric.
Yep. Very little like fine movement needed, unless you're doing like hand or something.
Right.
Yeah, I did a cardiovascular surgery rotation. I was like, I couldn't do this, but this takes too much precision. But the knee replacements, I was like, I can do this.
Done. Right, it's carpentry. Yeah, you're a carpenter. This is perfect. That is so funny.
But I like rehabbing them after they have that done.
I think the lifestyle is a little bit better too.
Right, that's cool.
Yeah, it is. No, I have a question. What advice would you give to people who are in residency now and it is November, they should, PGY4 should start looking for a job? Definitely. If you haven't, what advice would you guys give them? This can kind of be like a group question. Start if you haven't. Number one.
Yeah, I mean, look at what are the aspects of the job that are most important to you? Is it the location? Is it schedule? Is it compensation? Think about what's most important to you, and then go from there. Look for a list of jobs that at least fit those, and then find out what your next priority is.
And you mentioned like opportunity for growth too, so that's a good question to ask when you're on interviews, whether in private practice or if you're doing inpatient. Is there opportunities to become medical director, or if you're doing academic kind of research and all that kind of stuff? So that's something that may not be on top of everyone's mind, but this is your career and you want to keep growing in your career. So what are some ways that you can do that?
And I think Jason brought it, like a good place to start is your program director as asking for jobs, because typically they know, they're in the know, they talk to so many other program directors, so they'll know who's looking. It's always a good place to start. Yep. Carter asked a question.
Yep.
You want to go ahead.
How much of your outpatient practice patient base is a result of your inpatient work?
It was probably 60%, 60-70%. And then I started getting more, referrals from family doctors and, in the network, and then even some workers' comp cases. But probably 60%.
Are you doing any EMGs?
Keeping me busy.
You doing any EMGs?
No, I wasn't then. I want to, and Botox and.
Yeah. You get there.
Gotta get the equipment to my office to be able to do that.
Yeah, for sure. Absolutely.
What about you, Benecia? Is that for your outpatient clinic? What percentage? Yeah.
My outpatient percentage is probably like 10-15% from inpatient rehab. They usually go to Dr. Shaw will see most of those for hers, but most of mine is just from primary care referral. But actually, there's like a few that I'm like very attached with from being on the acute side that will then follow up with me, or I'll just happen to be like the only one that's on their insurance, or if there's like a very specific date, then they'll go ahead and follow me. But yeah, the majority, it's like probably like 80% of Dr. Shaw's is the follow up from there for her.
Yeah.
But unless it's best, she doesn't do Botox, but I will be this. If it's Botox, I will follow up. She'll send them to me for spasticity management. Yeah, but no, it's a perfect way to grow your outpatient if you can do both. Absolutely.
Yep. Good question.
They're rolling in.
What do you wish that other medical specialties knew about the field of PM&R in regards to helping their patients?
Send them to us before you send it to surgery.
Sorry,
Hands
what did you
down.
say?
We
Nisha,
just
go ahead.
don't just write Norco scripts.
Yeah, yes. Send to us before you send to any kind of orthopedic surgeon or, yeah, let us try to get them better.
We're the experts in function and quality of life. Those are the two things that we stress out all the time. And we try and get patients better when possible without surgery or with, just using more conservative options. So,
and surgeons actually prefer it. Like, we had a conversation with a neurosurgeon recently on our podcast, and like when they have a patient coming from us, they are having surgery. Like everything is teed up. They've done everything they've needed to tee them up. So yes, give the patient a chance, because surgery should be the last option, not the first.
And learning how to say our name and what PM&R stands for. It's not pain management in rehab. It's
not plenty of money in rehab.
Yeah.
And relaxation. Physical medicine and rehab.
And that's the thing, when you go out and practice, you'll know there are other physicians that don't even know what PM&R is. And so that will be
don't have a clue.
Marketing, and you'll have to either make presentations or just meet, face to face with people and just kind of explain this is what you do. And once you do, they love it. Like
they do. I have I was telling Omar last week, I have a couple of my referrals. They've sent their spouses to see me. I was like, oh, that's such a good feeling. I was like, oh, they trust me with their family.
Exactly. That's how you build your practice. That they'll start friends of friends and family members, and
Yep, and just kind of saying yes to everything and trying to help everyone. And if you can't help them, that's fine, but like sometimes it's just literally listening to what's wrong with the person because they've been brushed off by so many people. But I'm like, no, something's wrong. I might not know what it is, but I'm gonna try my hardest to figure it out for you. And if I can't, then we'll get you in the right hands. But yeah. What other question? Oh, so Sheena kind of brushed on it, but when it comes to studying for boards, you talked about earlier, we did a very unique thing, and we highly stressed it to our underclassmen. I don't know if they did what we did, but they weren't the dream team. Literally, we were such nerds. We started July of our PGY 4-year. We took, because there was 12 chapters of Cucurilla, we split it up and we made an outline, and every month, never failed, we studied and reviewed it. So when we took our in-service exam, literally our scores were 1 point. Like it was like someone got this one, this one, which it was good because Dr. Hamilton's like, well, clearly we know you guys been studying together.
Yep, and if you have if you go to a residency program with a large group, like if there's like 9 in your class, just find, 1 or 2 people that you get along with really well and you study well with, and kind of use them as your study buddies. So.
Yeah, because it's such a huge part of your residency. We spent so much time with each other, especially like Jason said, our PGY 2 year, like it was us 3 in the resident room for a long time. So we got to get a chance to bond and get to know each other. And we try to do a lot of stuff. We made it a point to do social stuff outside of work as a group to really bond, which was fun.
I love you guys. Miss them.
I know. I have a question. How do you guys, I thought we were all excellent residents. How do you become a good resident? What's your definition of a good resident, guys?
Someone who shows up, works well together, is a team player, all like it sounds trite and trivial, but you would be surprised that that doesn't always happen. And then just knowing, and sometimes like in spinal cord injury, brain injury, you'll know maybe like a day ahead of what kind of patient is coming in. So kind of reading up on that. It's a brain injury and they're like minimally conscious, kind of going through, what that means and the different levels, and kind of just being able to show your attending that, you're interested. And even though that's not something you may want to do, it's still, part of your residency and part of being a PM&R physician. And kind of, when it comes to getting recs and once you graduate from residency, you're not done with the program. Dr. Hamilton always tells us that you will always need her for
always
jobs or credentialing. Things will come up, so you don't ever want to burn bridges with the people you worked with in residency.
Mm-hmm. Yeah, I think you hit a huge one. Be on time. Like, just show up on time.
Yes.
Because you can't do any of the other stuff if you're not there.
Yes, or be ahead of time is even better. If you can get there before you're attending, that looks even better. But don't be there after that. That will piss them off.
Be prepared. Yeah, like Sheena said, read up, so you know either about your patients or about a condition that one of them has, so that you know about it and can offer some knowledge. And always be learning. Be willing to accept criticism, not acting like you know everything already, because you clearly don't. That's why you're in the residency, to learn some more. But yeah, being humble enough to accept criticism and if you read about it, offering what you do know and sharing the knowledge both with your fellow residents and with your attendings, so you can discuss it. And, if you're trying to do what's best for your patients, your attendings are not going to be, they're not going to be upset about that if you disagree with them, or offer another alternative solution.
Yep.
What's up, Justin Gasper? He just said hi. And I think being a team player, you said that earlier, but there's been plenty of times. So when we took call at BIR on the weekends, the resident would be responsible for the admission. There's been times where we had 11 admissions in one day or in a weekend. And these two we've been like, I will write the H&P for you. Like, let me know if I need to come in and help you. So if you're a team player, like, you treat people how you want to be treated. There's going to be a time you're going to need help. So just make sure you're able to offer that help. And I also think, like, when you're in residency is not fun. Like I said, like, it's fun, but like, you're there to learn. So there's going to be times where you're not going to like it, but that's just part of being in residency, right? And we're PM&R residents, so it's not like we're pushing 150 hours a week. So let's be honest, like, we were there maybe 40 hours, we work in 40-hour weeks. So learn who to complain to. So I have a funny story about me complaining that I had an admission early on, and I had to wait for my attending to come around with me, and it was like 4 hours later. And I was so mad about having to wait, but like, I just complained to Jason and Sheena about it. Like, I didn't complain to anyone else. So I went and saw the patient with my attending, and then like later on that night, my attending sends out the email. She's like, "Oh, Benecia was so gracious. She waited for me. She was patient." And I was like, "See, it's because I didn't complain to her. She didn't know, so know who to complain to." Because it could come back and bite you in the butt, or it can be something good. Hopefully you'll have someone like the dream team to complain to. What else we got, guys? Anything else?
Any other questions out there? Great questions.
Yeah, those are good questions.
Christian Carter.
Well, I guess we'll get ready to wrap it up then, huh?
Wrap it up, yeah. Jason, thank you so much for joining us. Super fun to see you.
Yeah, thank you. It was good to see you guys, ladies.
Dream team back in action.
Hopefully it's not 10 months again before we see you.
I know. And we're still doing our IG takeovers, so it's the interim season is up and running, so feel free to reach out to us. We had Case Western, I think, was our last IG takeover a couple of weeks ago, so so yeah, so please reach out.
Yeah, and we'll be still posting daily content, but we are taking a break next week, but we'll be back on November 22nd. We have Dr. Marina, who practices PM&R and palliative care, so that will be interesting to hear about, because that is another option to get fellowship trained in out of physiatry. So we'll see you guys in 2 weeks. Bye.